On nous jamais. Namanale. 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 Manu York, yeah. Yenn saay ci sama bésu neex sama xel dem ca fama jóge woo yenn saay sama xel dem ci nit ñu baax ñamu séqaloo ngir mënoo fàtte ki la yaataloon jamais. Namanale. 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 Manu York, yeah. Yenn saay ci sama bésu neex sama xel dem ca fama jóge woo yenn saay sama xel dem ci nit ñu baax ñamu séqaloo ngir mënoo fàtte ki la yaataloon jamais. Namanale. 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 Manu York, yeah. Yenn saay ci sama bésu neex sama xel dem ca fama jóge woo yenn saay sama xel dem ci nit ñu baax ñamu séqaloo ngir mënoo fàtte ki la yaataloon jamais. Namanale. 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 Manu York, yeah. Yenn saay ci sama bésu neex sama xel dem ca fama jóge woo
Hi, Judy, you're muted, please. You're muted.
So sorry about that. Good afternoon, everybody. Good afternoon, good morning. I'm particularly conscious that our friends from the west coast of the US, it's very, very early in the morning for you. So for all of you from that part of the world, welcome. Thank you for being part of us. For the rest and majority of us here in Africa, good afternoon, good morning in the west coast, welcome. Really, it's a wonderful way to close the year. I know this, I think, is almost like our last week of, fully working. And from next week onwards, most of us will be taking some time off to spend with our friends and loved ones over the holidays. And as we come to a close of the year, I think this opportunity accorded by the Second International Conference on Public Health in Africa, CPHIA 2022, allows us to really highlight and showcase and spotlight the wonderful work that Africa has been doing. I was particularly excited about the theme for this year, which is looking at Africa post-pandemic and some of the lessons learned, and that will form the thread of our discussions this afternoon. We're going to look at what AFREhealth did during the pandemic, what lessons did we learn, and what does it mean for Africa as it responds to public health threats in the future. My name is Judy Hanyola. I'm the secretary of AFREhealth, and another hat that I wear, I'm the chair for the Center for Nursing and Midwifery at the University of Global Health Equity in Kigali, Rwanda, which is the host of this second public health conference. It's actually happening right next to me, next door at the Kigali Convention Center. So many people, I can see them out there taking part physically, and many, many more of us taking part virtually. I think this is going to really be our new normal, as many of us can't travel for one reason or another, but do still have the opportunity to partake of the knowledge and the information that comes out from convening such a place. Today we have a really scintillating next 2 hours for you to discuss different things, to bring to the forefront challenges that Africa is facing, but also solutions that Africa is providing for itself through AFREhealth. I have a plethora of eminent, preeminent scholars from within and from outside Africa, many of whose bios, if I was to start reading them, would probably take more than the 2 hours we have for this side event. I wouldn't even do them justice by doing that. But this afternoon, we are going to hear from Ambassador Eric Gooseby, who is going to talk about the journey of AFREhealth and how does AFREhealth's past shape its future? What did we as AFREhealth do right? What did we do wrong? And what should AFREhealth do to continue being relevant both to the global north and to the global south? We will have this will be followed by a panel discussion, and we will talk about how AFREhealth responded to COVID-19 pandemic. And last but not least, we'll hear from the first African PEPFAR head, Ambassador John Nkengasong, and he will be, beaming via satellite. He's in Washington, D.C., and talking about AFREhealth as an interprofessional organization, and perhaps telling us a little bit more of how we can work together. So without further ado, I would like to, it's my honor, my privilege to introduce Dr. Eric P. Gooseby, who is an internationally recognized expert on infectious diseases, who has participated and developed program and policy at the highest levels of government. He currently holds a distinguished professorship at the University of California, San Francisco, known as UCSF, the MacArthur Foundation Chair in Global Health Sciences. He began his career treating HIV/AIDS patients at San Francisco General Hospital as part of the early leadership responding to HIV in San Francisco then, which was obviously, as we all remember, the history of HIV, battling HIV in those early years and also across the US. In 1991, he served as the U.S. Department of Health and Human Services as founding director of the Ryan White Care Act, a program that brought care and treatment services to 52 epicenter cities and all 50 states in the United States. In 2009, Dr. Gooseby was appointed by President Barack Obama to be ambassador at large in the U.S. State Department and the Global AIDS Coordinator, charged with the implementation of the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. So it's really good that we now have a new PEPFAR head who is talking to us. What a meeting at the crossroads of such a thing. During his tenure, Dr. Gooseby, the MEPI and NEPI programs were established. to strengthen nursing, close to my heart, and medical education programs across Africa, and to address the health workforce priorities necessary to secure PEPFAR's goals. In 2015, Dr. Goosby was asked again by the UN Secretary General Ban Ki-moon to be the UN Secretary General's Special Envoy on TB, tuberculosis. In this role, he has worked to raise awareness of TB and help implement known solutions to address the critical problem of increasing deaths worldwide from this curable disease. Dr. Goosby holds an MD from the University of California, San Francisco, where he attended medical school and did his internal medicine internship, residency, and fellowship. Dr. Goosby, as well, he has extensive publications in clinical medicine, clinical guideline development, program implementation, and policy issues in both domestic and international arenas. He is an elected member of the National Academy of Medicine. This is what I think really a summarized version of Ambassador Goosby's illustrious career. We're very happy to have you here today, Ambassador Goosby. Over to you.
Well, thank you so much, Judy. What a kind introduction. I thank you for that. Well, what a long journey it has been. The MEPI-NEPI vision back in 2009 was one of trying to develop a platform that supported young faculty who were mainly playing both clinical backstop for teaching hospitals throughout the continent of Africa, and were also in a position to see the issues that presented themselves to clinicians, to healthcare professionals, providers, and oftentimes in my experience with HIV, the best questions, the correct questions to raise an inquiry around, to do research on, really came out of a combination of those individuals who were in front of the clinical demands, but at the same time were part of the institutions that preceded the outbreak, in this case HIV, and had the expectation by society and policy leaders in country to play a leadership role in understanding the threat and responding to it. Our hope was that the demands put on the clinical system in Africa during the early 2000 years showed us that oftentimes our colleagues in teaching hospitals were putting students directly in front of clinical dilemmas, patients, covering hospitals, emergency rooms, et cetera, for both maternal and child health, as well as adult and pediatric cases, but were not given the alternative support to develop the skill sets to refine and ask the correct clinical questions that needed a further clarification to understand the best way to respond to them. Clinical research, implementation research, having the ability to see a problem, break it into its component pieces, and understand how your current delivery system with its portfolio of interventions and services that you already brought to the problem, now being challenged by a new problem, has an expanded need to develop new answers, new strategies to respond to the changing needs of the population that you're already responsible for. Getting a faculty that had resources to carve out of their clinical time to both learn methodologic, experimental design, curriculum, but also the clinical teaching skills across the bed for what at the time was a rapidly evolving new disease including health professionals that either did not have a sophistication with HIV, although all had seen it and responded to it. This was taking and trying to bring an academic medical center capability into ministries of health to try to concentrate the talent that could identify, describe, as well as be aware of the clinical response to that same threat for how people are identified, entered, and retained in medical delivery systems. That individual, that faculty member in both nursing and medicine needed to be supported to expand their knowledge and understanding so they could indeed play that dual role of clinician and clinical scientist. It has been breathtaking to see the types of activity that the original MEPI-NEPI cadre have been able to start up and continue. I think that the convergence of the capabilities that we see in and around the HIV needs, from prevention to diagnostics to therapeutics to the procurement distribution systems that are needed to support that, and the formularies, that larger orchestration of expanding and constant needs already being challenged by by NCDs, not being part of the focused portfolio of the PEPFAR effort, realized that the platforms that PEPFAR built were going to be central and part of that larger need that those same patients who are HIV positive and in PEPFAR care have with hypertension, diabetes, coronary artery disease, et cetera. COVID was the quintessential slap to all of our delivery systems around the planet. Our ability to understand that indeed this presented a new threat and what that threat would look like as we better understood how the virus moves through individuals and what that clinically looks like, how we follow that with diagnostic capability, developing those along the way, and understanding both mitigating and prevention efforts that decrease chances for transmission as we better understood high-risk groups for contracting COVID and the overlap we see in the community response to contact tracing and case finding that COVID needed coming out of a TB and HIV cadre of individuals in most settings really did show us that that ability to expand to a new need and contract as that need recedes is going to be a capability that the world now needs to put in place. The AFREhealth cadre of clinical scientists and clinicians and health professionals is just the type of network that is needed to rapidly move information to patient populations and health professionals as a new threat presents itself. And a cadre of individuals that can be the repository of unanswered questions that those in front of the outbreak begin to feel are important to better understand, so decisions can be made to again minimize exposure and transmission rates. The PEPFAR platform was used in this way. We feel it could have been more aggressively used and used earlier, but it did play that role because, in large part, because it could. And I think it made everyone realize the importance of this surge capability and the importance that the partnership between academic medical centers, people who have clinical skills and also methodologic research skills can more rapidly move through a body of unanswered questions to make decisions in real time with limited information, sometimes with no information, because you don't have the luxury not to engage. I think that the COVID challenge that presents to us, and Dr. Ambassador Nkingasong's vision that these platforms need to be focused on what the service delivery portfolio contains, how that relates to a health system strengthening agenda for the HIV, for COVID, and for NCDs, but at the same time, not losing track of goals and objectives that are defined for each of the diseases that we already have assumed responsibility for, specifically HIV and TB. I'm confident that the platforms that you are in and work in and support are the central platforms that are going to take the response on the African continent to what I would call a more robust understanding of a defining of the threat, the populations that have different threats from the same organism, and what are the implications for the delivery system as you develop and implement strategies that identify, enter, and retain people in care for either the duration of their life with HIV, or are there for patient information, for modifying behavior to minimize transmission, as was with COVID and TB, but also as we realize that the responsibility we've already incurred in assuming HIV coverage and care also includes responding to the needs of that same HIV positive patient as they present with needs with their blood pressure, with diabetes, with coronary artery disease, et cetera. I believe the blanket of capability that PEPFAR has positioned to synergize with domestic efforts in each country now need to look at itself more specifically around the completion of those continuums of care as we better understand an expanded need that must be put on an already engaged platform. You are going to be the leadership that takes this further down the road. The PEPFAR of the next 5 years is out of necessity going to have to play a central role, look for opportunities to be foundational pillars of expanded capability as we move into expanded threats. So it's been an honor to have walked this path with you to this stage, and I am more than optimistic that the understanding of the role AFREhealth has played in the last decade is something that not only is needed now, but is the preferred model that I believe we need to use as we strengthen our healthcare delivery systems for these expanded pandemic threats. So I will stop there and open to questions or however you'd like to handle it.
Thank you very much, Ambassador Gooseby, for your very profound, I think, and very, timely, I think is the right word, remarks, particularly in the place we find ourselves in Africa here in 2022, coming out of, COVID, but still battling other health threats. We see Ebola, we see monkeypox, we see many others, and then we have issues around, perhaps because we were busy fighting the pandemic, then other things fell by the wayside. And then this has also now reared its ugly head, and we really are facing many challenges. And I think the work that you do and the support that you've given and the learning that has come out of that is very, very useful for us at such a time as this. I want to open it out, please, to colleagues around the world. You've listened to Ambassador Gooseby, he's right here in front of us. Please, you can either type your question in the chat or just put your hand up or unmute yourself and speak, whichever works best for you. The floor is open to us at this time. Once again, thank you, Ambassador Gooseby.
It's a pleasure. as people are thinking about questions, it's about understand the importance of these partnerships between academic institutions in nursing and medicine, the role that we have turned and expected with healthcare workers, how that relates to the role of nurses and doctors, where they start, where the nurse and doctor begin, and the arrow going in the other direction, is something that has decompressed demands and needs, but it and is definitely central to the solution, but it is not the only answer to an expanded demand on healthcare, on the healthcare workforce. We need to continue to strengthen the partnerships between the academic institutions in a country and the ministries of health at all levels as they define and implement their response. So all the more reason for this institution, the AFREhealth community, to understand its central role in that.
Professor Maswa.
Hello, Eric and all, and Judy.
Hi, Francis. Wonderful to see you, my friend.
Indeed, 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 indeed.
You look younger.
I hope so.
Yeah.
I've been moved to speak really as a celebration, celebrating AFREhealth, where it is now, and also our history. It is great to see people like you, Eric and Judy. I can see Marike and Fatima, and of course our current president, Elsie, and many of the names here, Abigail. It is an excellent Christmas gift for me to be able to see all of these people with whom we have journeyed together. And of course, to celebrate you, Eric, for that support, which together with NIH and so on, enabled MEPI and NEPI to grow, do their bit, and now bring in other health professionals into our vision. And we have, I can tell you, Eric, that AFREhealth is very busy. These people who take leadership, they meet every week. I don't know what they talk about. They have a meeting every week. And there are so many projects which are going on all over the place. And hoping and believing that they are all promoting those ideals of better quality education and the leadership role of health professionals, educators, bringing their students along with them. And of course, for COVID, we have held several webinars on this. And 2 weeks ago, I think we held also a webinar on Ebola in Uganda, which brought top people on this issue of Ebola. The very person who described Ebola for the first time, Jean-Jacques Muyembe, was talking to us, and another veteran from Uganda here, Sam Okware. He was written 3 or 4 books on Ebola now. And this is, Eric, what is happening here. And I want to congratulate everyone, the leaders who have brought us here. And I look forward to a future of Africa with an institution like this, which is sorely needed. And we need African institutions like AFREhealth to be working in cohesion with others at the continent and not in competition. And really, I don't know whether John Kengasong is on the meeting now. This is my message for him, help us to make African institutions more cohesive. But we have a great one here in AFREhealth. Merry Christmas to you all.
Well, thank you so
Thank
much.
you.
Your comments were wonderful. I know in talking to the ambassador that his vision is strong. He has a deep understanding of the burden of disease and the response to it from many specific sites in the country. So his knowledge is deep, and his commitment could not be purer, if I could say it that way, to find the role that a platform such as PEPFAR must play in looking at that expanded demand, disease burden, and the response to it. Also, looking at the ability to solidify the relationship of the faculty of AFREhealth, the cadre of clinical scientists in both the medical and nursing arenas, are something that NIH, being deeply skilled in looking at the toolbox of the clinical researcher, the clinician scientist, is in a deeply informed position to play more of an orchestrating role in the AFREhealth portfolio. So we're eager to solicit more of an oversight role for Fogarty NIAID in getting the 7 institutes in NIH that have supported AFREhealth to reaffirm their commitment for another decade and to look at collaborations in both curriculum, which I think you have excelled at, and the training back and forth where individuals are brought in limited time frames, weeks to months, to learn new clinical methodologic skills that they can apply in their settings at home with a mentor relationship established in Bethesda, NIH, et cetera. That commitment is stronger. We see the cadre of clinical faculty who have come forward in both nursing and medicine. There's a group that now needs that further mentoring. And I think Francis has been, for many years, a leader in understanding that need, seeing that need before many. So I know that the ambassador's commitment to that vision is strong.
Thank you, both Professor Francis, Ambassador Gooseby. I'm just reading the chat. Somebody says, hi, everyone. My name is Dauda Niarie from Mali. We welcome you, Dauda, and you'll find that AFREhealth is really working hard to make sure it's really the face of Africa across language, across geographical, across all the barriers that we've had historically. So it's really great. Welcome from Mali. We hope you continue to be part and parcel of AFREhealth. AFREhealth can only move forward by individuals such as yourselves taking part. I have a question here for you, Ambassador Gooseby, from Dr. Modibo Sangare, and he asks, any clues on funding opportunities? And here he is saying that, and he's joined by Simon Pius, who says, I also have the same question. We are not given opportunity to access research grant fundings. Any way out through this forum, excellent leaders in health research, please, Simon Pius asks this question. Professor Modibo's question is 3-part. He looks at community-based information, education for behavior change to prevent mother-to-infant HIV transmission with midwives and community health workers as the central pillar of interventions in developing countries such as the ones we have here in Africa facing multidimensional crises. So, Ambassador Eric, it's a bit of a mouthful, but I think you're up to the task.
Well, an appropriate question. I think the community that has been part of the AFREhealth journey is, I think, especially ready for that relationship to be complete. The co-PI the kind of relationship where you bring in a US or European principal investigator. I believe we are at the cusp of a pivot where institutions like NIH, like the Wellcome Trust, like Gates Foundation, see the need to develop those principal investigator relationships with African researchers. We have been in dialogue for years around this, as I know many of you have, but I believe the willingness and ability to make it real is just on the horizon. And I believe Ambassador Nkengasong includes this vision in how he thinks about things. But we have to answer to people that control the checkbook, but we've learned how to talk to them in a way that that emphasizes the lack of wisdom that not bringing people into a PI relationship represents. So strong advocacy. I believe we're on the cusp of it. I believe we've got agreement from many of the critical pieces. And I think, so I think a traditional R01 type approach to funding is what our goal is. K award type buttressing and backstopping is what we hope to be able to do in this next phase. Fogarty, NIH, NIAID, HRSA, Center for Disease Control, have been talking about this really for about a year and a half, with COVID derailing all of those discussions. But we're back at it and committed to it. I believe I'm speaking for everybody who's a stakeholder in that dialogue, and everyone feels it's time. So a commitment to do that. I think the other line of funding that I would just highlight, networks such as AFREhealth need to think of themselves creatively as an entity that carries a capability that crosses geographic jurisdictions and can give a larger footprint for population inclusion. If you can start presenting yourself with ideas that cross those kinds of geographies that align with your leadership, this would be an attractive approach. Ambassador Nkengasong's vision is one of a regional capability, being the kind of motor resource that emanates out to country specifics from this regional kind of organization. So, so thinking in terms of a pandemic preparedness, how does your platform better enable those responsible for surveillance and response to do their work better, to do it accurately and completely? You can play a central role with that because you are actually in, I think, the best position to play that orchestration over jurisdictions. So something that we're thinking about and want to bring that dialogue and discourse to you. But I believe there's fertile fruit to reap in that arena.
Thank you, Eric. Pascal Felix, I see your hand up. Go ahead.
Greetings, everybody. Quick question. In terms of PEPFAR, what limitations have you seen when it comes to that general approach?
So, so let me just share with you the dialogue that's going on in kind of the larger PEPFAR community. The individuals who have a 20-year relationship with PEPFAR in and around the HIV focus of PEPFAR have always been concerned that PEPFAR remain focused on the burden of disease that HIV presents, and have been worried about what is perceived as a mission creep off of a HIV agenda. I have really since the end of the 90s in basically standing up the program that was the PEPFAR program for indigent AIDS care in the United States. The same mission, the same systems were stood up for the Ryan White Care Act in the United States that we later did in PEPFAR and started in 1991. So we've got a lot of water under the bridge for that in 52 different epicenter cities in the United States. AIDS dedicated clinics as well as primary care funded clinics in general medicine and pediatrics that are capable of caring for HIV and not AIDS dedicated. That those outcomes and those systems of care are really the platforms that were needed in responding to the COVID threat, the health, the human resources that were already engaged in TB, HIV, and to a degree in malaria were used, piggybacked on to focus for both patient information and education, provider education, curriculums were shared through all of these platforms very quickly. But the ability to move to diagnosis and treatment to get therapeutics that came and were used off of these platforms is happening at a much slower rate. I believe we can tone the system so either with repeated variants that COVID presents or with a new threat, as well as the continued demands that HIV and TB make, this platform needs to be understood and tested to expand its capability to be there to diagnose and treat the other diseases that are now killing the HIV positive individual who we have on antiretrovirals, but are not diagnosing their diabetes, their high blood pressure, or their coronary artery disease. So the pivot into primary healthcare systems and at the same time, not losing the outcome and objectives that we already have assumed for HIV and HIV TB and PMTCT is going to be the focus. I am confident that you're already doing this in most of the settings we're in. We just need to understand that better and then be aggressive at it, because the need of the population we're already responsible for, the HIV positive individual on antiretrovirals, their needs are the need to diagnose high blood pressure, diabetes, and coronary artery disease, et cetera. So that pivot to that larger need. The second of NCDs, et cetera, using the platform, it's the same need that pandemic preparedness should play, taking advantage of these already stood up interfaces with populations that to a large degree are trusted by patients and families that have credibility in bringing and explaining a new threat to a population. So taking full advantage of all the work that's already been done by the HIV/AIDS effort off of that PEPFAR platform. We now need to continue that, but to embrace the expansion.
Thank you very much, Eric. And I think the work that you've done in your career, even as I was reading your bio and just reflecting a little bit, is very useful for us now, because we need to not think that the answers are magically somewhere, that we spend so much time looking for them, but really to learn the lessons from what we've done that's succeeded well. And like you mentioned, the tremendous work that PEPFAR has done since the beginning of the HIV pandemic in the early 80s in the US, and then creeping over into Africa, and the challenges that we face because of that, and not just HIV as the disease, but its spillover, the learnings we've had around the impact it's had on vulnerable populations, on women, for example, on children, on communities, and so on and so forth. And I think what PEPFAR started, in the US and came over to Africa, Africa also then made it its own, in a sense, if I can say that. And we began to, I did a lot of work in Uganda in the early 90s as a HIV nurse. Just the sheer force of numbers, for example, allowed us to have a few nurse-led interventions that we learned quite a number of lessons for example, the ability to prescribe first-line regimen for patients, and how that helped, because the doctors and the systems were overwhelmed, and things around, even initially when people thought we couldn't understand this, we couldn't do this, patients couldn't understand complicated medication regimens and things like that. So I think for me, that's a very good learning for us now, having now gone through COVID. What are the things that something worked in the past well that we can take on for the next new threat that comes, or the new challenge that we face? And I really liked that about what you said. Ambassador Gooseby, thank you so much. Really, for me, the fact that you continue to be with us so many years later is such a testament to your continued support for the work that AFREhealth is doing, and the fact that you can come in and always kind of speak from that experience is very helpful. I've really taken notes from what you've said when you're saying that AFREhealth needs to position itself as a regional capability. I like that, and I'm glad that our president and our executive director are here this afternoon to begin to see how to take that wisdom you're giving us. How do we become the engine for the region in some of these areas around? You mentioned pandemic preparedness. How do we orchestrate over jurisdiction? You said that. So we have Francophone Africa, we have Anglophone, we have Lusophone, we even have Arabophone, hoping to tap into that in the near future. How do we bring all of that? The one thing I like for me as a nurse is the interprofessional aspect. So nowadays, I never imagined that I would be in the illustrious presence of very many medical doctors who are now listening to what the nursing and midwifery profession is doing, to what community health workers are doing, to what other clinical sciences can bring to the table. And that is really, really good. And we're beginning to see that working together is better than working separately. So thank you so much for gracing our side events with your presence. I know it's very early for you. Happy to drop off if you need to take a well-deserved, catch some shut-eye, but please, if you can be part of us to the end, you're most welcome. Your thoughts always, always, always welcome. Thank you, colleagues. I want to move to the next part of our side events. We have heard about the journey of AFREhealth from Ambassador Gooseby, who has told us about AFREhealth's past, about the PEPFAR thoughts in those early days. And now we want to move to the present. What did AFREhealth do in response to the COVID-19 pandemic? And what does this mean? Because it's all well and good to talk about we did this and we did this. And while it's important to hear of these interventions, I think it's even more important for us to learn from these interventions and what we can do for the future. So I have a great group of folks, as they say in America, spread from all over Africa, who've really done tremendous work in AFREhealth, who are going to tell us a little bit about their work. I'm going to introduce them one by one on the panel. We have Fatima Suleiman, we have Jean Nashega, we have Marieke de Villiers, and we have Fred Semitala. I will start, our panel will just simply be very straightforward. We're just going to ask them a few questions, which will allow them to speak a little bit into what they did during COVID in AFREhealth. I am going to start with Professor Fatima Suleiman. Fatima Suleiman is a professor in the School of Health Sciences at the University of KwaZulu-Natal and Professor and Director of the WHO Collaborating Center for Pharmaceutical Policy and Evidence-Based Practice, which sort of tells you that Fatima is a pharmacist by profession. She is a former Prince Claus Chair of Development and Equity, Affordable Biotherapeutics for Public Health until September 2018 at the Utrecht University in the Netherlands, and a Fulbright alumnus, a scholar from 2002 to 2004. She has been appointed by the South African Minister of Health to serve on the National Pricing Committee and served as the chair of the Pricing Committee from 2014 to 2020. She has been appointed to the World Health Organization's Expert Advisory Panel on Drug Evaluation from 2017 to 2021. She's also an executive committee member of the African Forum for Research and Education in Health, our very own AFREhealth, and she's also one of the principal investigators currently of the NIH grant that has been supporting a lot of the work that AFREhealth has done. She has served on a number of WHO committees over the years and been a technical advisor on pharmaceutical policy for a number of countries. She has a number of publications in the area of pharmaceutical policy and medicine use. And Professor Fatima, we're very excited to have you. Personally, I count you as a very good friend and colleague. And so right over to you. I want to ask you the first question. COVID made us pivot to online learning, whether we were ready or not. Why would an LMS being a learning management system, be important to an organization like AFREhealth? You're surprised that I'm not asking her pharmacy questions, but Professor Fatima is the head of our learning management system at AFREhealth. Over to you, Fatima.
Thank you, Judy, and good day to everyone who's here from all parts of the world. I have to tell you, Judy, I was tired just listening to that introduction. So let's talk about AFREhealth. So let's put some things into context. You know, AFREhealth has part of its vision of leadership, this need to sort of bring, to build a strong, skilled health workforce. And I think all the previous speakers have alluded to that. And the focus is on looking at effective, efficient systems to deliver quality healthcare services. And a lot of it is also to do about ensuring access and equity in this care, but to also make it evidence-based, you know, to make it relevant for our context and local context. Because like we've mentioned before, our challenges are complex. You know, we have so many scarce skills across the continent. So part of what AFREhealth was driving at was a collaboration across professions, you know, rather than having these vertical alignments, is to actually have this interprofessional connection and this interprofessional network. And in this way, scale up sort of things like best practices and innovations, you know, mobilize all kinds of healthcare professionals across the Anglophone, the Francophone, the Lusophone countries in Africa. So the learning management system came about as a sort of a base to get all professions across the region. So not just within one country, but across all of these countries, across language groups, across different healthcare systems, to come and talk about best practices and to learn together and apply these lessons together. So it was meant to be, and it is, this platform where people can come and share experiences. And I think that our other speakers on the panel are going to talk about it, but COVID created this lovely opportunity for South-South collaboration to happen across this network, and for training when there were these restricted and very sort of strong lockdown measures by governments across the world, but also in Africa. So clinical training was not as easy as it could be. Access to services was not as easy as it could be for healthcare professionals that were also undergraduate, or those that just came out and were having to deal with something like this pandemic. So what happened during COVID, even just before that, AFREhealth set up this learning management system, and then working with our partners in UCSF, which Mariki will talk about later, is really then pioneered a way to get a whole lot of people together across professions, across these continents, to come together and learn together on quality management, and not just for HIV, but for COVID as well. And everybody at that point was struggling to understand how to manage it. So really, it was an ideal way to be able to do this. And I'm not too sure if you'll allow me to go on for just a minute or two more, Judy, as well. But I think that in this process, there have been strong connections developed by groups across the continent. You've talked about having medical professions listen to you. You know, I as a pharmacist get to work with a lot of healthcare professionals, but pharmacists from other countries as well, to share experiences, to create collaborations, to be able to do other research projects together, to be able to talk about what's missing within our continent, that we can then develop further modules for training and for fostering this network even further. So I'll stop there because I know you have others that you want to ask other questions too.
Thank you very much, Fatima, for that. Our next panelist is Professor Jean Nashega. Jean Nashega is a professor extraordinary of medicine at Stellenbosch University, Faculty of Medicine and Health Sciences in Cape Town, South Africa, as well as a tenured associate professor of medicine, infectious diseases, microbiology, and epidemiology at Graduate School of Public Health, University of Pittsburgh in Pennsylvania in the US, and an adjunct associate professor of epidemiology and international health at Johns Hopkins Bloomberg School of Public Health in Baltimore in the United States. He has over 30 years experience in patient care, teaching, designing and implementing HIV/AIDS and tuberculosis studies or programs funded by NIH, NIAID, NIH, the Wellcome Trust, PEPFAR, and EDCTP. He has authored more than 210 peer-reviewed publications, including in top-tier journals such as The Lancet, the New England Journal of Medicine, JAMA, Clinical Infectious Diseases, and Annals of Internal Medicine. He's an ad hoc consultant at WHO, CDC, Bill and Melinda Gates Foundation, member-elect of the Academy of Sciences of South Africa, and an African Academy of Sciences fellow. Really, Dr. Jean CV is just outstanding. But today we are going to focus on research. Jean, can you tell us what strength or value add does AFREhealth's research agenda bring?
For that kind of introduction, will it be possible for me to share just a few slides?
Absolutely, Jean, absolutely. Secretariat, can we allow? Yes, good, great.
Thank you. Here we go. Can you see my slide?
Yes, Jean,
Yes.
we can.
Yes. So thank you, Judy, for that question. So as we've been talking, I think I just gonna have a few minutes sharing the experience that through the lockdown pandemic, we've been able to, as AFREhealth member across doctors, nurses, pharmacists, and many others, we've been able to share, to work together in terms of research. And not every HIV research was shut down, but by default, we all have to divert to COVID research. And this really adventure, we really started in DRC, in Democratic Republic of the Congo, as Francisco Maswa mentioned. Leader like Jean-Jacques Muyembe, the co-discoverer of the Ebola virus, he's part of member of AFREhealth. I just reached out to him and say, Jean-Jacques, you are the COVID task force in DRC. What is happening there? At that time, we didn't know what's going on COVID on the continent. And Jean-Jacques was so kind and humble to say, Jean, come here and we can share the data we're collecting as part of routine data we are collecting here in DRC. And we can look at what's happening on the African continent. And we were so blown out when we look at the results that the picture on the continent is somewhat different of the picture coming from America, from Europe, in the sense that children were dying at a relatively higher rate than other places where it seems that the children are less affected and less likely to die. But also we learned that people ending in ICU and adult ending in ICU had a mortality almost of 50%. So while African continent were less likely to be a Holocaust, but those who are affected, mortality were high across demographics. So we galvanize using those pilot results from DRC. We say, okay, we cannot transpolate what is in DRC, and that was small number. Let's look across the AFREhealth network. So we capitalize on our network in West, Central, East, and Southern Africa. We pull 6 countries. We wrote 2 protocols. Really, this was an amazing journey to try to come together and to just do research. This was the first time we could galvanize across several countries to do this. So the result, to keep the story short, we ended up publishing this work, at least for the children in JAMA. Really, we confirmed that so those are the 6 countries: Ghana, Nigeria, DRC, Uganda, Kenya, and South Africa, across 20 sites. We confirmed that mortality in children was almost 10%. So that is about 10 times higher in Africa than what was reported from China, from United States, and from Europe. And that most people were likely to end up in ICU. And so when we adjusted our results, we were also blown up that not all children were equal. Infants were at even higher risk of mortality, and comorbidity specific on the continent like HIV and TB increase the risk of COVID in this population. So those are, so our work were quite disseminated widely in the media, and it's currently cited for government guideline to support COVID vaccine. So we also look at several other groups, including mostly pregnant women, what's going on the continent. And this was also a collaborative work we did with many members of AFREhealth that some are on this call. And again, we were able to evidence that pregnant women were 2 times likely to die compared to non-pregnant women with COVID. But also those women who are COVID positive compared to those who are COVID negative pregnant, they were about 5 times more likely to die. So those are adjusted data. Again, here we also documented that HIV, specific comorbidity like HIV or history of pulmonary tuberculosis, were a high risk of mortality, about 2 times higher mortality in this situation. So again, our work is also being part of guideline, both under Ministry of Health and government. So so this is just to end to say, really during the COVID pandemic, AFREhealth, we learned to how to work together to do high impact research that end up to public health policy here in terms of supporting COVID vaccine. And we look forward to continue again to work together as we embark in the new chapter post-pandemic to try to see how we can continue to do valuable research to try to make a difference in the daily life of our people. And especially in the context of COVID vaccine, where Africa has been lagging in terms of coverage. This is just an example, a meta-analysis showing that only 20% to pregnant women in South Africa are likely to accept COVID vaccine. Vaccine hesitancy, while it's a global problem, it's even higher in Africa, and including in some vulnerable group like pregnant women, where they have a lot of factor that can motivate why they are hesitant of the safety of their infant and so on. So we are in process of designing innovative multi-component intervention to try to address vaccine hesitancy in pregnancy and other vulnerable group. We welcome Ambassador Gooseby the possibility of accessing further funding to try to continue our work, because really we are not out of the COVID as some people may think, and vulnerable groups are still being affected and continue to get high morbidity and mortality. We don't want to make the same mistake we did for HIV. So we need to learn from the HIV to try to see how we can scale up most of those interventions that are evidence-based on the Africa continent, including vaccine and therapeutics. So I'm stopping here, and just again to thank AFREhealth, NIH, PEPFAR, for all the support they provided us for AFREhealth, and more specifically from my work for the research of trying to get to know, to work together. The SAF-SAF collaboration, I think AFREhealth has been the leader, but also the interprofessional. It's been fantastic, a really amazing experience for me in research to work with pharmacists, nurse, and all other cadre to try to come up with high impact research. So thank you so much, Judy, and I'm happy to discuss further. Sorry, I was a little bit take a little bit more time. Thank you.
Thank you very much, Jean, for that wonderful presentation. Jean has really spearheaded a lot of the work we are doing under research, and it's really great to see the multi-country approach that he has been so successful to do so far. And really, Jean, I applaud you in this great work that you're doing. My next presenter, and we will have time to ask questions. Fatima was looking at our learning management system. Jean has given us a glimpse of some of the great research work that has been done by AFREhealth under COVID. And now I want to take a moment to introduce our next panelist. Her name is Professor Marieke de Villiers. She's a past president of AFREhealth, and we've really grown just because of her leadership with us. Professor Marieke has dedicated more than 20 years of her academic career to strengthening health systems through building human resources for health in South Africa and the African continent. As a family physician, she has been passionate about addressing the needs of communities and spearheaded many innovative health professions education initiatives that has produced research evidence of delivering transformative learning in medical and health professions education. She has also served as the Deputy Dean at the Faculty of Medicine and Health Sciences at Stellenbosch University for 10 years, building extensive international networks. Professor Marieke has a long and illustrious CV that I wouldn't do justice to read, but she has over 37 peer-reviewed articles on interventions in the health professions education pipeline, and has forged several collaborations with 11 African countries in medical education, e-learning, family medicine, and scientific writing. Professor Marieke, I could go on and on, but I think this just goes to highlight that you're the best placed person to talk about a learning intervention that AFREhealth has been doing with support from UCSF and a lot of the work that you've done there in different African countries. Thank you very much. And Professor Marieke, I just want to start by asking, how has your work with Stripe, I think you'll tell us first of all what Stripe is, changed or improved public health in Africa?
Thank you, Judy, for that kind introduction. Good afternoon, ladies and gentlemen. I just want to check, Judy, can you hear me well? The sound is okay?
Yes, Marieke, we can hear you.
Okay, great. Thank you for the wonderful opportunity to see old and new friends. It's really lovely to see how AFREhealth is still growing and being active and at the forefront. So let me just tell you what, for those who hasn't encountered, STRIPE stands for Strengthening Interprofessional Education in HIV and COVID. And immediately I have to acknowledge our partners. Dr. Reed was on the call at the beginning. I'm not sure if I'm still seeing him, but University of California, San Francisco, they are our main partner in this project. They are the people who really spearheaded this project, and I must acknowledge Michael and Deborah von Zinkenagel, who are the current PIs, as well as Professor Gooseby. They were the think tank behind it. And then our funders, which is the HRSA from the US, I would really like to thank them also. So STRIPE represents a multi-country capacity development initiative. It started in 2019. It's covered 15 African countries at the moment. Of the very important part of this is interprofessional, so diverse cadres, nursing, therapists, pharmacists, medicine, lab technicians, some even trained, some administrators. So the interprofessional nature of the project is very important. The target initially was mostly pre-service and newly qualified health professionals. But as from year 2, this is broadened to include in-service training as well. The content currently consists of 20 modules on the LMS, of which 17 are HIV modules and 3 COVID modules. There are also 2 interactive workshops available that you can present to your people, and that's one on teamwork and collaboration, and another one that we developed during COVID called Wellbeing and Compassion, which was really very much welcomed in that very difficult time for the health profession sector. We have reached more than 13,000 learners by now. 5,000 in the first year, which was mostly before COVID. And then in 2020, since 2020, another 7,000, which is actually, we've stepped up that numbers. We've used 3 modalities. Firstly, face-to-face training. And with the advent of COVID and with the help of the LMS, the learning management system, like Fatima mentioned, we've really robustly escalated the training using 2 modalities, namely virtual workshop, which means basically a Zoom workshop supplemented by material. And secondly, the other modality was online training, which was mainly the LMS training, which, as you know, needs lower bandwidth, but has less interactivity. So Dr. Reed and a number of our esteemed colleagues have done an extensive evaluation, and I'm just going to mention 1 or 2 things from this. The article is already been submitted and is in the process of being corrected and will be published. Please read it. It makes for very interesting reading. So first and foremost, it's shown that a significant rise in both knowledge and confidence across all three the modalities that I mentioned. So improvement in both knowledge and confidence. And there was a small comparison between the two, which I am not going into now. What was very interesting in terms of the second year, the COVID year, where we escalated to the online and virtual workshop training, is that it appears that it increased access to previously marginalized professions. There were statistically significant more females entering the programs, which has got something to do with females caring for the household, doing all sorts of things, don't have time to go away for training, being with the family. And we also saw an increase in the diversity of the cadres, the professions. So that we were very happy to show that not only did the online version also increase knowledge, a little bit less confidence because it wasn't the face-to-face, but it did increase confidence, but it increased the reach of training. So maybe I shall, your question was, how did we change, improve public health in Africa? So I would like to say with that brief look at what have happened to these 14,000 plus diverse cadres of health professions, is that each and every one of them has taken something into their practice. So our next challenge is actually to show what impact it has made in practice. And I hope that Fred will talk about what they are doing in Uganda, where they're actually exactly doing this, showing the impact in clinical areas of this training. So I will pause there and wait for questions. Thank you, Judy.
Thank you very much, Marieke. And that's, I think, just a small snapshot of the Stripe work that has been done in the last 2 years during COVID. I want to just finalize our panel this afternoon by turning it over to service delivery and to give us a few nuggets of truth and wisdom is Dr. Fred Semitala. Dr. Fred is a senior lecturer, Department of Internal Medicine at Makerere University, College of Health Sciences, and the Executive Director for Makerere University Joint AIDS Program, MJAP. He is a physician and public health specialist with over 20 years of HIV/TB care and programming, capacity building, and implementation research. His research focuses on integration of evidence-based interventions into programs to improve outcomes for HIV and HIV-related comorbidities. He is a co-principal investigator on a Fogarty-funded capacity building program for implementation science research at the School of Medicine, Makerere University. He is also the Ugandan co-PI with Professor Nelson Sewankambo, also of AFREhealth, for the education for interprofessional HIV service delivery, which is part of what Marieke has just talked about, Strive HIV. Thank you very much, Dr. Fred. We're excited to have you here this afternoon. And I just want to get into it and ask you the question. What did you do with AFREhealth during COVID-19, and how did this impact service delivery, particularly, of course, in TB HIV care, of which you are an expert?
Yeah, thank you, Judy, for the kind introduction and for having me on this forum. Maybe before I answer your question, I would like to take this opportunity to appreciate the leaders in AFREhealth, and also thank Professor Guzbi for the tremendous work that he is doing behind the scene to make Stripe such a success. Like everybody else, we who work in the TB area, we noticed that with the upsurge of COVID, there was a lot of decline in the number of people who are screened for TB. In Kampala here, I think there was a decline of up to 38%. We've done some work which will be published soon. But as Marichi mentioned earlier on, I think when we had designed our training for interprofessional HIV care, we thought that it was going to be physical kind of interaction. However, that quickly became impossible because of the restrictions for travel and congregations. And so we had to move to online platforms. Of course, initially they had challenges. And as Mariki mentioned, we had thought that we would be training people who have just left school and those who were completing school at the time. However, we quickly realized that it was difficult to tag that kind of training to outcomes in terms of HIV indicators. And in our second phase of the training, we decided to target people who were already in service. And to do this, we initially partnered with colleagues at the Infectious Diseases Institute, and we worked with several facilities where we interacted with the healthcare providers. Maybe to back up a little bit, we have a lot of success stories in Uganda for HIV care. For example, the program which I lead, our viral suppression is 98%. Retention for 1 year is about 93%. But if you look in more detail, you find that there are subgroups who are not achieving as good care as others. And these include men, they include adolescents and young people, and also the cascades of prevention and care for the key populations also lag behind. So we worked with the healthcare providers within these facilities, and together with them, we are able to look at their data using the district health information system to see those indicators where they were not doing very well. And together we came up with those indicators, those areas of concern, and we aligned them with the STRIPE HIV modules that Mariki has mentioned, part of the 17 modules, including viral suppression, retention in care for the key populations, but also initiating and completing pre-exposure prophylaxis. What I can say is that with that kind of training, we created a group of practitioners who were able to respect each other's views and consultatively come up with programs that could address those indicators that were not up to scale. And within just 8 weeks, we observed tremendous improvement in terms of them developing and line listing trainers. I mean, patients who were in those cascades that were lacking behind. And over the past 1 year, we've expanded that to include 17 more facilities and trained over 240 providers to improve these indicators. And we think that working with people who are already in practice and helping them to approach these gaps in an interprofessional manner helps them to create a sustainable service delivery while also directly impacting on the PEPFAR indicators. I'll pause there for now, but we'll be happy to take some questions related to the clinical care that we have provided as a result of being part of the STRIPE HIV program. Thank you. Over to you, Judy.
Thank you very much, Dr. Fred. And your work really is very exciting because I think it's just demonstrating how AFREhealth's either education and research then also translates into improved outcomes on the ground when we look at service delivery. And I particularly like the interprofessional aspect of it because, again, it's just, together we are stronger. So I'll take this pause at this time to please, again, if you have any questions, put them on the chat, unmute yourself and ask. You're free to ask questions to any of the panelists. Just for reminder, Fatima talked about learning management system that AFREhealth has in place and what we have done. Jean was taking us and talking to us about research. Marieke talked about the STRIPE work, and that is interprofessional education. And Fred also talked about service delivery, particularly focused on HIV and TB care. I see a few questions on the chat, and I think this comes from Pascal. He asks, when it comes to HIV/AIDS populations, do you experience supply chain issues? For example, access to therapeutics. Perhaps I will ask Fred to tackle this, and then maybe Fatima as well.
Yeah, I think that's a very good question. So we are again doing some work in that area. And what we noted was, of course, because there was, you know, the lockdown definitely affected people from getting their care. But what we did, and working very closely with the Ministry of Health, people were allowed to access HIV services at the nearest facilities, but be in touch with their primary providers so that they know. And overall, what we've observed from the work we've done, both from Kampala and also southwestern Uganda, it clearly demonstrates that while there were some challenges to HIV care in terms of access to care, but also mortality related to COVID in HIV, what we found out is that probably because of the strong system that the PEPFAR team and the Ministry of Health has set up, it was easier for people living with HIV to access HIV medications, even during that difficult period. Sometimes we would actually individually carry medications to our patients, because for us, we were allowed to move about. But in the same vein, we also noted that, for example, people who had both HIV and NCDs were more likely to have complications, and were unable to access their medications for non-communicable diseases, although they were easily able to get the medications for HIV. So that is what we have, and we are soon publishing some work in that area. Over to you, Judy.
Thank you, Fred. Fatima, what would you say around supply chain issues, maybe just based on your experience?
I think it differs from country to country, so it's not possible to make a kind of unilateral a response to that. But I think that a lot of countries are supported by programs that provide funding for treatment, so it shouldn't be a problem. And I know that during COVID, also in lockdown situations, people were allowed to come and collect like 3 months supply, 6 months supply. Prescriptions were extended just to improve access and to increase sort of people being maintained on therapy. The problem, though, was not the therapeutics during this time. It was more about people who might have just, you know, would have been newly diagnosed with HIV or TB or any of those sorts of conditions, who stayed away from the healthcare system because of lockdown situations and fear of getting COVID. So there were delays in therapy maybe for those groups.
Thank you, Fatima. Jean, your work in research is very interesting, but just moving away from the specifics of it, I would just like to ask you, how is AFREhealth's research strengthening Africa's capacity? There's always another school of thought which says Africa should not focus on research, but more on service delivery. We don't need more evidence, we need more doing. What would you say around, you know, how AFREhealth's research is strengthening Africa's capacity to deal with some of the public health threats that we face today?
Thank you, Judy. I continue to support that we need the research on the African continent to try to drive public health policy and clinical guidelines, because as our work just showed, driven by AFREhealth, you cannot always extrapolate the finding from from outside Africa to Africa, because we have our own specificity in terms of health system, in terms of comorbidity, in terms of, so it does not make any sense to copy paste, data that result from Europe or United States. So we need our own data. So we need the research. We need to advocate for better research, high quality research, and most of all, we need to really to invest in implementation science, which is it's an important area of research. Most of findings sometimes are not implemented to make a difference. They end up in New England, but then they don't translate to the ground. So we need really, so I really advocates against people who think that we all need together, and it's COVID just re-emphasized how important we need to understand what is happening on the continent. Everyone was saying, Africa going to be devastated. So why that never happened? So there is so interesting work why that did not happen. But when those who are affected, there was also a lot to learn from. So just as an example. Thank you.
Thank you, Jean. And Jack Mukubwa actually echoes what you're saying. He says you are spot on, Jean. Africa needs its own researchers because of its own unique needs, and I completely concur. Professor Maswa, your hand is up.
Good afternoon again, friends. I've been inspired to put my hand up because of that question on research and your comment, Chair Judy. Earlier in November, I participated in a meeting in Miami on it was called International Conference on the Future of Health Professionals Education. And this topic came up. And my own upbringing at Makerere Medical School so many years ago was that service, teaching, and research are inseparable. And it was described as the three legs of the African stool. If one of the legs is not there, the stool is unstable and you can't use it. So I don't know how much more I need to say, but the elaboration is there. It's very powerful. That you cannot first as clinicians or lecturers, we must treat patients. And because we are treating patients, then we can teach. Your students will follow you around and see what you are doing and learn from you. And then because you are serving, you are teaching, there will be questions in your work that you will have to improve the way you perform your work. So you must do research to answer those questions. And no one should be able to say that a clinician can practice effectively without having research as part of his armamentarium. So I just wanted to say that from a long time here at Makerere, that was our approach. And let's just consolidate it and not weaken it. I think the fear now is that in some universities, they are researchers and clinicians and they are separate. There may be a few like that, but the majority of researchers and clinicians should be one and the same person advancing better care for the population. Thank you.
Thank you, Prof. Maswa. I'm almost tempted to change our logo to have that stool. I think it's such a powerful image, especially of Africa and that three-pronged approach. Perhaps quickly, Dr. Fred, I would like to ask you in the same vein of just what we are discussing. How can AFREhealth then, you are talking about service delivery, can we strengthen our impact on service delivery as an interprofessional organization and not remove ourselves, for example, from education and research? What would you quickly say on that?
Yeah, thank you, Judy. Definitely, we can strengthen the impact of AFREhealth on service delivery by bringing together people who are already in service, especially because you know what we've learned from providing HIV care is you need to have some indicators, and you need to have in place a mechanism to monitor those indicators, because you can't keep working very hard, but when there is no starting point and end point. But I think also what we've observed by working through the STRIPE program is that sometimes people work together in the same place and they have a lot of skills, but these skills provided sometimes to the same patients, but in a very disaggregated way. And so I think what we need to do is to create that forum where people provide patient-centered care as a team, that they focus on the same patient or on the same issues, but have an opportunity for each one of them to bring out their ideas so that they can be able to look at patients more comprehensively. I mean, we are having challenges. For example, we are trying to work in that space where you have someone coming to the clinic and they get HIV care from one corner, and then they have to either go to another clinic or another day, or even come to the same clinic but another day to pick antihypertensive medications. So we think that if people are trained to offer interprofessional services, they should be able to actually address this care, but it's not going to happen in a vacuum. And also the other thing that we've seen that is quite successful is again working with these practicing teams to come up with continuous quality improvement projects, and with a forum where they can sit together to evaluate how far they have moved from where they started. And these have actually demonstrated, and they are sustainable because people are working in the same space. Of course, sometimes we have a staff turnover, but the majority are going to be there for a while, and they can, if we approach it the way Professor Omaswa has described, where you provide a service and you're training and also you're doing research, even if it's operations research, I think these are the approaches that are really going to be sustainable and help our providers continue to provide quality services to our patients. Thank you.
Thank you, Dr. Fred. Lastly, I want to ask Marieke, just again, based on this generalized topic around the three-legged stool of service, teaching, and research. How is AFREhealth, what is AFREhealth doing to continue the work of STRIPE, and how will it sustain it? What are your thoughts around that specific piece of interprofessional education, and how will AFREhealth continue to sustain this moving forward?
Thank you to all the speakers for your interesting comments. Yes, you would see behind me, there's a logo of AFREhealth, University of Stellenbosch, and a boat metaphor. So one of the things that we were tasked with is to develop a facilitators course so that we have a cohort of master facilitators for AFREhealth that will continue to train facilitators for learning, and that will continue to train the content that AFREhealth has at the moment that we talked about, the modules and the workshops. So I see actually one of our people that attended the course, Jennifer, is on the call. So Stellenbosch University, together with AFREhealth, has developed a course called Facilitation for Learning that we've presented over the past 7 weeks, where we really go into, we've recruited advanced facilitators, already facilitated HIV training. So we go into advanced techniques and principles for small group facilitation of learning. And in the same instance, we need to research the effect of that. So that's and in the same instance, those facilitators will implement this in-service training. So there's your 3 legs of your stool. So that's one of the mechanisms we're doing to ensure the sustainability going forward of these this interprofessional capacity development initiatives, whether it's in service, online, or virtual workshop. Secondly, the learning management system is key for us, for AFREhealth, providing sustainability going forward. What we found in this course that we've just completed is that even experienced facilitators are not familiar or easily work with the LMS. So we will do some capacity building with that, because that is one universal tool that we've seen. We were able to rapidly scale up training via remote mechanisms using these online technology. AFREhealth is also engaged into various partnerships, and Georgina may want to answer on that. There's one with the university which name escaped me now, also on COVID. In the States, there's one with a university in the UK. So starting then from PEPFAR projects, AFREhealth is engaging in a variety of multinational North, South, South partnerships in strengthening our base, as well as strengthening our capacity to do this training, as well as to research what we are doing and if it is making a difference. And then we will sit comfortably on the stool without falling off. Thank you.
Isn't AFREhealth a wonderful place to be? I think this is just showing you the length and breadth of the work. There's so much more. The 2 hours wasn't sufficient, but I think it's giving a glimpse of how AFREhealth is beginning. I think for me, what I've liked being an African living in Africa is beginning to now work together, to stop replicating, to stop duplicating, to stop competing, to stop nationalistic way of thinking, but to move into a kind of working together across countries, professions, disciplines, age, seniority or junior, senior, and so on. And I think the fact that a lot of the knowledge has also been vested in such capable people, the stellar people you're seeing on the panel today, really gives me comfort, because I know the excellence within which the work that we pull out is just like world class. It stands the scrutiny, it stands the test of time. So I think all of you on the call just know that AFREhealth really is the place to be if you're genuinely interested in moving the needle on health professions, education, service delivery, and research. But all of this cannot happen without something I think is critically important, and often I think sadly lacking when we look at our political leaders, leadership. So AFREhealth has also taken a front seat in leadership, and I would just like to ask, and the right person really to ask this is our executive director, to tell us a little bit about the James Hakim Leadership Program. What is it? And maybe you can just take a minute or two to say, why is health professions leadership development important? And what should be done to translate this education and practice into impact on the ground? Over to you, Georgina.
Thank you very much, Judy, and hello, everyone. For our James Hakim Leadership Development Program was instituted last year, as 2021, and we had a second session in 2022. We noted that health professionals go through their training and they become service providers or researchers along the line, faculties. They also develop within their career, becoming heads of department, deans, and provosts. And a lot of them have not had any leadership capacity building, and they struggle. And so AFREhealth, together with the University of California, San Francisco, saw the need to develop this program to be able to build the capacities of our mid-career faculty so that they can become the change agents that their institutions need, that Sub-Saharan Africa also need. And so we began thinking about it, and for the first cohort, we decided to pick 40 people. How did we go about this? Initially, we decided that we were running the Stripe project. We already had our implementing institutions, and so we used our implementing institutions, and then we asked the PIs to nominate the fellows for us, and they did that. The second year, we did an evaluation of the first year, and one of the comments that we had was that we needed to open it up to our entire community instead of looking at the PIs and the implementing institutions. And so we decided to do that. We opened it up to the entire AFREhealth community, and we were able to enroll 28 participants for the 2022 one, which ended in September this year. The method that we've been using on this project is that we do workshops as one, and they are every other week. And then also we have small group sessions where we divide our fellows into groups, and then they discuss the topics that they treat at the workshop. We also have mentorship, where we have our experienced AFREhealth members and other dedicated people from our partners who voluntarily mentor our fellows. So we pair them up, and they set up the times that are convenient for them to do this mentoring. And I must say that through this, some of them have been able to establish longer-term mentorship, and it's really helping them. I remember one of our mentors indicating that with her help, one of the mentees was able to write a grant, and she was successful with that. Then also we have another session which deals with project work, where people develop projects that they can implement in their institutions. So our coordinators help them for them to be able to develop the projects that they will be able to implement after the course. But we don't provide funding for that. They will have to look for funding to support that. Then throughout the program, we expect that all our fellows will fully participate in the projects that they are doing and in the program as well. And I must say that as humans as we are not able to get all of them participating, but majority of our fellows are able to go through this program, and they have wonderful stories to share. One of our fellows is on this program, and I sent him a message. I want to find out from him if he would like to share his experience as Professor Modibo Sangari, if he's available to share what he learned from the project, because that would really be a life story than what we are saying, because we are telling people, but when you get somebody who has gone through it, sharing his experience, that really resonates with people. And I must say that from the first evaluation that we did from those who completed in 2021, we noted that they had started practicing. Some had had opportunity to become leaders. Others also were training other people in their institutions for them to also acquire these knowledge and skills from the leadership training that we had for them. And so I would want to find out if Prof. Modibo is around to really share his experience with us. And he is one of our trainees, and then also he's become a regional lead for West Africa. A regional lead for West Africa. We also have another regional lead in Southern Africa, Patricia, who was a fellow in 2021, and in 2022, he was one of the coordinators and also a mentor herself after being mentored. So Prof. Modibo, if you are available, I would seek the permission of Judy so that you can also share your experience.
Absolutely, Georgina. Let's hear from the horse's mouth, so to speak. Professor Modibo, are you there? Are you able to tell us one or two things about what you learned with the James Hakim Leadership Development Program? I know we put you on the spot.
I sent him a message prior to that, so that is why I'm asking whether, yes, I sent him a message
Good.
prior to that.
I don't know if I see him here. I don't know if he is, but you know, sometimes we have challenges. So
but just to conclude, Judy, I would like to also say that we are going to run the program, but this time we will do it on the LMS. We want to put it on the LMS, and we're also going to institute another one on mentoring, solely on mentoring, because AFREhealth has a lot of experienced people, and we don't want them to go without mentoring others. Yes, they are doing, but there are more people coming up, and then we want them to also mentor them. And so for 2023, that's one of the things that we are going to do. And then also another area that we are also considering is teaching skills. Teaching skills, as I indicated, people are brought in, they become faculty, but they need that skill. It's very important, and AFREhealth has seen it as part of faculty development, and we are going to work on that. Thank you very much, Gigi.
Thank you, Georgina, Executive Director of AFREhealth, for just giving us a snippet of the leadership development. And I think this just shows us very clearly that AFREhealth is really looking at where the pain points are in Africa, and making sure that now we are soothing the patient, we are healing the patient, we are making sure that the patient goes home when they are well. And we are just really doing everything using an interprofessional, patient-focused lens. I want to bring this side event to a close and really just want us to hear, it's a very short clip, a video recorded message from Ambassador John Nkengasong. John Nkengasong is a Cameroonian American virologist, and he's currently serving as the Global AIDS Coordinator in PEPFAR in Washington, D.C. He previously worked as the director of the Africa Centers for Disease Control, Africa CDC, Disease Control and Prevention, from 2016 to 2022, as well as at the WHO and Centers for Disease Control, CDC, in the US. Dr. Nkengasong was appointed as the WHO Special Envoy for Africa during the COVID-19 pandemic, and he graciously recorded a video for us as AFREhealth. Let's take a moment and listen to what he is telling us in AFREhealth.
Health systems and institutions will be critical for the continent of Africa to continue to prepare to fight the current HIV pandemic and other emerging disruptive outbreaks and pandemics. We've seen that during the current COVID pandemic, and we saw that for the past 40 years as we struggled to fight HIV/AIDS. Going forward, a major lesson we have learned from the current COVID pandemic is that we have to look at our ability to strengthen service delivery, strengthen health systems, and strengthen the institutions. There's a direct correlation between the ability to deliver services properly to the community at need and the systems that are required to deliver them properly. as well as the institutions. Services do not deliver themselves. They require resilient systems, for example, workforce, supply chain management, laboratory systems, good information systems, and supply chain management to be able to deliver properly. At the same time, those systems are reliant on functional institutions. Without strong institutions, systems do not function. So we need to work hard to close the loop between the service delivery systems strengthening and public health institutions. The underpinning of all of that is the workforce. We know, and we've known this forever, that perhaps, and just perhaps, a competent workforce is the backbone of any functional health system. A competent workforce is the backbone of every functional and efficient institution. So we need to be very deliberate and intentional in expanding our workforce at all levels, including with the community. Community health workers are key. As we've all said multiple times, it starts in the community and ends in the community. We need to also look at laboratory workers, experts in not just those who do the diagnostics and the testing, but those who manage and lead the lab operations. And then on top of that, epidemiologists. We've come to a point that we were able to define, for the interest of global health security, that we need one epidemiologist per 200,000 inhabitants of population. But we've not been able to define that for nurses and laboratory experts. That is some work to be done. Setting targets and meeting those targets in terms of workforce development is so important and is critical as we continue to fight the current HIV pandemic and prepare for subsequent ones. Above all, it has to be competency-based workforce development. We cannot expect that community health workers will just do what they have to do, go home and feed their families or nothing. We have to be very deliberate that we need to pay community health workers. Just dumping additional work onto community health workers who are already overwhelmed with their current routine activities will not work, will not take us to where we have to go. Let me just say that as a continent, we know that the need is for 6,000 epidemiologists to be trained for a continent of 1.3 billion people. The current numbers, as best as I understand from my time at the Africa CDC, is that we have 1,900 epidemiologists. So there's a gap right there of about 4,000 that we need to train. But as we look at that, and the nurses, we need to broaden the training aspects for the nurses that are taking care of the HIV work and equip them, capacitate them, and enable them so that they can be able to dictate any unusual occurrences in their workplace, like a new disease, and report that to the nearest district or central laboratory or district surveillance systems. That's what we mean in PEPFAR by elevating the public health systems. We should just imagine if the national public health institutions that we have all created are enabled to do a couple of things: to expand workforce, work on the emergency operations centers, good information systems, and coordinate laboratory networks. Then we would have enabled that country to be able to fight the current HIV pandemic, but position it such that it can very quickly fight other disease threats. PEPFAR has done this in the past effectively through the nursing program and the medical education program. Those are platforms that can be built on very quickly to expand that at country level and build more partnerships. PEPFAR cannot do this alone. PEPFAR will require appropriate partnerships. That is why in our new strategy that we released on the 1st of December, we emphasize the need for transformational partnerships that will bring more resources and assets from their unique perspective into the ecosystem so that we can truly train public health workers and workforce, not just nurses and doctors, but as I've emphasized earlier, community healthcare workers and laboratory experts. It is a combination of these workforce that will enable us to be better prepared for tomorrow's challenges, which we've all known it will happen. 1 year ago or 2 years ago, we didn't just know that we'll be challenged with the magnitude of what we are dealing with, which is the COVID pandemic. We just don't know what is at the corner. So the best time to prepare for that pandemic, that unknown, what WHO calls disease X, is to do the things that I have said. Example, working with the private sector to expand workforce development, to train more epidemiologists, but retain them and make sure they have quality jobs in terms of career movement, upward movement in their careers. That is the only way we're going to prepare for the next pandemic and make sure that it doesn't surprise us the way this pandemic does. So it's been a pleasure to have been invited to contribute in this session. I thank you all for the opportunity.
Very wise final words from Ambassador Nkenga's song, and I think it gives us a lot of food for thought as AFREhealth. And as we come to the end of this session, I just want to hand over to our president, Dr. Elsie Chiguli Malwade, to just give us the final words. Over to you, Elsie.
Thank you very much, Judy. I'd like to take this opportunity to thank the organizing committee of CPHIA 2022 for giving us the opportunity to hold this side event. Thank you very much, Judy, you are the secretary for AFREhealth. You've done a great job convening and running this meeting smoothly. We really appreciate you. I would also like to thank Ambassador Eric Busby. Thank you so much for standing with us. We are going ahead because we are standing on your strong shoulders. So we appreciate all the work that you do behind the scenes, making sure that the vision that you started does not stop. And we are really willing to work hard to make sure that we sustain AFREhealth. I would also like to thank Dr. John Kengsong for his words of wisdom and for agreeing to be part of this side panel. I would like to thank our panelists, Fatima, John, Mariki, and Fred. Thank you so much for sharing your insights on the different aspects of work that AFREhealth is handling. And all the participants, thank you so much for joining this side event. And if you are not a member of AFREhealth, we would like you to join AFREhealth. This is exciting work that is being done in Africa. Please join us so that we can make Africa a better place to live for everybody. And as we continued with the discussions, I could see clearly coming out the issues that AFREhealth is handling: partnerships and collaboration, interprofessional education, leadership, creativity and innovation. And this is all aimed at working across geographic jurisdictions to create change agents that can make Africa a better place, that we can look after patients better, that we can, as health workers, perform better and lead to better health outcomes. So AFREhealth is committed to doing this. I know we have come to the end. We have run over time, so I don't want to keep you longer than we were supposed to, but you've heard from the different people that have talked what AFREhealth is doing. And there's much more, and you can visit our website and see more of the work that AFREhealth is doing. I would like to thank all our funders. You've heard about some of them during the different speeches that have been given. Our partners that are working with us, and well wishers for supporting us. You are all very, very much appreciated. As we come to the end of this year, I'd like to take this opportunity to wish you all a prosperous and promising 2023. Thank you, everybody that has been with us for these 2 hours. You are very, very much appreciated. Over to you, Judy.
Thank you, President. AFREhealth. AFREhealth is a great place to be. we just want you to switch on, if you can, your videos. We are taking a screenshot of this great place called AFREhealth. Just a second, the tech guys will do that. If you can, switch on your videos. Wishing you all a Merry Christmas and a Happy New Year. Thank you for supporting AFREhealth. Thank you for being part of AFREhealth. Thank you for all the great work that you do in your different places. May God bless you all. Thank you. Michael, have you taken it? You
Yes,
have?
I've taken it, yeah.
You have taken both screens, because we have two screens.
Yes, I have on the second screen now.
Good. Fantastic. Thanks, guys.
Thank you. And thanks a lot, Judy. Wonderful.
Happy New Year, everyone.
Happy New Year.
Happy New Year. Bye.
Bye.
Jesus, greetings.
Yes, and to you.